Thank you, everyone. So my name is Micheal Choi. I'm an assistant professor here at UCSD. So I'll be talking about the brakes, or how to restore the brakes. I guess I didn't have a disclosure slide, but this is not an approved agent for this disease. It is in clinical trials still. And our laboratories do receive some research support from that. So normally cells, normal cells during development or without cancer are programmed to die when they detect that there have been damages to their DNA or other things affecting them, or when they just outlived their intended life. So typically a normal cell will perhaps detect genetic errors. That's detected by a protein called P53. And that sets in motion a series of events that leads to the death of a cell in the programmed manner. And that programmed cell death is termed apoptosis. And what's happening on a closer level is that I guess the last series of events that leads to the death of the cell kind of are triggered at the mitochondria, which are kind of the energy factories of the cell. Typically, the mitochondria have proteins on them called BACs or BAC that are kind of guarded or sequestered by a protein called BCL2. When the cell detects damage, there are other proteins that come and occupy BCL2, releasing those other proteins, BACs and BAC. Those proteins then are able to form little channels in the mitochondria, leading to release of chemicals that then trigger the death of the cell. So for various reasons, CLL cells have high levels of BCL2, and that's perhaps one of the reasons they don't die when they're supposed to. So for that reason, now for some time, companies have been looking to develop drugs that mimic these BH3 proteins, these proteins that could come and bind and occupy BCL2. And the one that's now in development is a drug called venetoclax, or ADT-199. This is actually a slide to say that this is actually the end result of pretty remarkable chemistry. They took a previous drug called venetoclax. They saw where it bound to BCL2 and modeled that using X-ray technology, but also saw ways that it was perhaps binding not ideally, leading to other effects or side effects, mainly low platelet counts. They engineered a new drug. They designed and engineered a new drug that bound in the way they wanted to, and that was this drug ADT-199. It has been tested now in a few trials. The ones that have been presented publicly are both phase 1 trials. The first one was given when this was given as a single agent to 84 patients with relapsed or refractory CLL. The tested doses ranging from 150 milligrams once a day orally to up to 1,200 milligrams orally. It's all very promising response rates of about 79%, with a fair number of patients achieving complete responses, 22%. This is again a group of patients that had been refractory to other treatments. It also included a fair number of patients with the high-risk features of 17p deletion or resistance to fludarabine. At the time of this presentation, most patients had maintained their responses almost approaching 2 years. The drug was generally well tolerated. Neutropenia was seen commonly, but there was one major problem with it that was encountered early on, which is tumor lysis syndrome. Tumor lysis syndrome is what happens when cells perhaps die too quickly, or too many of them die at once. As the cells die or break open, they release their contents into the bloodstream, and those include things like potassium, which when released in too high a level can cause heart rhythm abnormalities or even stop the heart and lead to sudden cardiac death. The cells also release high amounts of phosphates that could interact with calcium and cause nerve damage due to low calcium levels or precipitate in organs. And also release high amounts of uric acid, and that could, when at too high level or uncontrolled, can result in kidney failure. I think before this regimen, this is not a very common occurrence in treatments for CLL. That's something that we were accustomed to seeing when we were treating more aggressive lymphomas or other cancers, but this is something that was seen early on this trial with ABT-199. When this occurred, to mitigate this risk, the trials were put on pause for some time and redesigned so that patients gradually increased their dose of ABT-199 over the course of several weeks. And patients with very large tumors or high white blood cell counts or compromised renal kidney function were hospitalized so that we could monitor potassium levels and uric acid levels and intervene at the very first sign of changes and not allow these things to go on undetected. Since those changes have been made, there haven't been any other serious events of tumor lysis in this trial or others. In parallel with that trial, or shortly after that trial, a second trial was done where venetoclax was combined with rituximab. Here, 49 patients were treated, also with the relapsed or refractory CLL. And here, doses were tested ranging from 200 milligrams to 600 milligrams. Ultimately, it was decided based on the tolerability and the results that 400 milligrams was optimal for this combination. The response rates were also excellent. 88% of patients responded. A high number had complete responses of 32%. And actually interesting to me is that even a higher number than the complete responders had negative minimal residual disease, so no detectable cells in the blood or bone marrow. I think anecdotally we've had some patients that had still some enlarged lymph nodes despite no evidence of disease in the marrow. Perhaps those are just scarred lymph nodes that are still enlarged on X-rays, on CT scans. Toxicity, again, was mainly neutropenia. I think we see that pretty much occurring in every patient at least one time or another. It's pretty manageable if it's detected. We give doses of Neupogen or Neulasta and haven't had problems with infections or febrile neutropenia. Nausea was seen, I think, more so at higher doses. I think that was one of the larger main reasons why the dose of 400 milligrams was settled upon. And as mentioned earlier, there were no further events of tumor lysis or serious tumor lysis syndrome after those changes to the way it's administered. So currently, the drug is still in testing. It's not an approved agent. There are a couple of trials that are still open or are being evaluated. So other combinations are being evaluated. It's being combined with Zyva in the trial that's no longer accruing, but perhaps we'll have some results announced at upcoming conferences. And it's also being combined with chemoimmunotherapy, the bendamustine rituximab regimen. It's being looked at in very specific indications or very specific circumstances, like deletion 17p. Also in a trial that isn't accruing, but may have results announced down the road. And also in patients that have had the kinase inhibitors previously and now need something else. It's also now being compared to other treatments, being compared to standard of care treatments in phase 3 trials, compared to bendamustine rituximab in patients with relapsed or refractory disease, and being compared to the Gazyva chlorambucil regimen as a first-line treatment. My thought is that some of these trials, the specific indications or the standard of care phase 3 comparative trials, will be what lead to the approval of this drug, hopefully, in the near future. Yeah, so that's it for my talk.